October 2023, St. Elizabeth's Medical Center, Boston. A woman named Sungita Rashid has just given birth to her first child, a daughter. Hours later, something goes wrong. Internal bleeding from her liver. It's serious, but it's the kind of emergency a hospital like this is built to handle. The fix is a small medical device called an embolization coil. Standard equipment. Every major hospital has one. St. Elizabeth's had one too, until a few weeks earlier, when the manufacturer walked into the building and took it back. Repossessed. Like a car with missed payments. The hospital owed the device company hundreds of thousands of dollars in unpaid bills. So the doctors did the only thing they could. They transferred a bleeding new mother to another hospital across town. She didn't survive. Her daughter will grow up without ever knowing her. And the question that haunted the nurses who were in that building, the question that eventually reached the floor of the United States Senate, is brutally simple. How does a hospital in one of the richest cities, in the richest country on earth, fail to have a device that costs less than a used car? The answer is not incompetence. It's not bad luck. And it's not the usual story about America's broken insurance system. The answer is that St. Elizabeth's, along with more than 30 other hospitals across 8 states, had stopped functioning as a healthcare business years earlier. It had been converted into something else, a financial instrument. A vehicle designed to move money from the wards, the supply closets, and the payroll upward, to a private equity firm in New York, a real estate trust in Alabama, and a chief executive with a 200-foot yacht. Over the next 45 minutes, we're going to follow that money. We'll trace how a Wall Street playbook perfected on retail chains and restaurant brands was quietly applied to the most sensitive infrastructure a society has: its hospitals, nursing homes, and emergency rooms. We'll meet the surgeon who promised to save Catholic community hospitals and ended up presiding over the largest hospital bankruptcy in decades. And we'll look at the hard data, because the most disturbing part of this story isn't one company's collapse. It's the evidence that the collapse was not a bug in the model. It was the model. Before we can understand what happened to those hospitals, you need to understand the machine that bought them. Not the cartoon version, the actual mechanics. Because private equity is one of the most misunderstood forces in modern capitalism, and its power comes from a structure most people have never had explained to them. Start with what private equity is not. It's not the stock market. These firms buy entire companies, take them off public exchanges, away from public scrutiny. And it's not venture capital, which bets small amounts on risky young startups. Private equity does the opposite. It borrows enormous amounts to buy large, established businesses with steady cash flow. The tool is called a leveraged buyout, and the word leveraged is doing tremendous work in that sentence. Here's the trick, and it's worth slowing down for. When a private equity firm buys a company for, say, $1 billion, the firm itself might put up only $200 or $300 million. Much of it not even its own capital, but money from pension funds and endowments. The remaining 70% is borrowed. And here is the part that sounds like it shouldn't be legal. That debt does not land on the private equity firm. It lands on the company being purchased. The target pays for its own acquisition. Imagine a stranger buying your house with a mortgage, and the mortgage bill arriving in your name. That's the architecture. From day one, the acquired company owes hundreds of millions it never chose to borrow, while the new owners charge it ongoing management fees, payable whether the business thrives or dies. The firm typically plans to exit within 3 to 7 years, ideally selling at a profit. If the company grows, the firm wins big. If the company collapses under the debt, the firm has usually already collected its fees, often recovered its stake, and walks away with limited legal exposure. Heads, they win. Tails, they win slightly less. To be clear, applied to a mattress retailer or a software firm, this is aggressive financial engineering, legal, sometimes even productive. The controversy begins with what happens when this machine, built to maximize extraction on a 5-year clock, is pointed at a business where the inventory is measured in human lives. Because in the early 2000s, the machine found exactly that target, and it found it irresistible. Why would Wall Street's most aggressive investors want to own hospitals at all? Margins are thin. Regulation is heavy. The customers are, by definition, sick. On paper, it looks like a terrible business. But look at it through the eyes of a fund manager, and American healthcare starts to resemble something else entirely: the last great untapped oil field in the domestic economy. First, demand is bulletproof. Nobody cancels their heart attack because of a recession. An aging population guarantees decades of growing volume. And after 2008, investors were desperate for anything recession-proof. Second, the payer is the most reliable counterparty on earth: the United States government, writing Medicare and Medicaid checks with mechanical regularity. Third, the industry was fragmented. Thousands of independent hospitals, physician practices, nursing homes. And fragmentation is the raw material of the private equity strategy known as the roll-up. Buy dozens of small players, merge them, and acquire something no small practice ever had: pricing power. And fourth, the one almost everyone misses: real estate. A hospital may run razor-thin margins, but it sits on land and buildings worth hundreds of millions. To a certain kind of investor, a struggling hospital isn't a struggling hospital. It's an undervalued property portfolio with an inconvenient medical operation attached. So the money came. Healthcare deals worth close to $1 trillion over the following decade, and change. By the mid-2020s, private equity firms owned roughly 460 U.S. hospitals, about 1 in 12 of the nation's private hospitals, and their reach went far beyond. As much as a third of American emergency rooms came to be staffed by outsourcing companies, the largest of them private equity-owned. Nursing home chains, ambulance operators, air ambulances, anesthesiology, dermatology, dentistry. Hospice care, yes, hospice, where the customer, by definition, does not leave a review. Healthcare is nearly a fifth of the American economy, and for most of a century, its ownership was boring: churches, charities, universities, local governments. Within 15 years, a meaningful slice of it had been transferred to firms whose legal obligation runs not to patients but to investors, on a timeline of 5 years, at a target return of 20% or more. What those firms did once they were inside? That was remarkably consistent. Consistent enough that it has a name. They call it the playbook, and once you learn its 4 moves, you will see them everywhere in this story. Every hospital system in this video, every bankruptcy, every closed emergency room, is some combination of these 4 maneuvers, each perfectly legal, each defensible in isolation. Together, they function like a slow-motion demolition. Move 1, the sale-leaseback. The new owners sell the hospital's land and buildings, usually to a specialized real estate trust, and pocket the proceeds. The hospital, which owned its campus outright, perhaps for a century, now pays rent on its own operating rooms. Forever. Rent that rises with escalator clauses in a business with 3% margins. It is the equivalent of selling your house to pay for 1 great year, then renting it back at a premium for the rest of your life. Move 2. The dividend recapitalization, Wall Street's most euphemistic phrase. The hospital is instructed to borrow money, and the borrowed cash is paid out to the owners as a dividend. Read that again. The company takes on debt so its owners can pay themselves. The owners get cash today, the hospital gets the bill. Move 3 is quieter. Management fees, monitoring fees, transaction fees. A steady drip from the hospital to the firm, charged for the privilege of being owned. And move 4, the roll-up, we've already met. Merge enough local providers and you can raise prices on insurers without improving anything at all. If this sounds theoretical, consider HCR Manor Care, one of America's largest nursing home chains. The Carlyle Group bought it in 2007, executed a $6 billion sale-leaseback, and watched the chain buckle under the rent. In the years before it went bankrupt in 2018, health code violations at its facilities rose 26%. Carlyle told reporters it had ultimately lost money on the investment. What it did not lose were the fees it had collected along the way. Rent extraction, borrowed dividends, fees, and consolidation. 4 moves. Now, hold that playbook in your mind, because you are about to watch a single company run all 4 simultaneously at maximum intensity on a chain of Catholic hospitals in Massachusetts. This is the story the United States Senate would later spend a year investigating. It begins improbably with a heart surgeon who was supposed to be the hero. Boston, 2010. A hospital chain called Caritas Christi is in trouble. 6 Catholic community hospitals, the kind that serve nurses' unions and dock workers in immigrant neighborhoods, founded by the church more than a century earlier. Pension obligations are crushing. Buildings are aging. Wealthy patients drift to Harvard's glittering teaching hospitals downtown. Caritas needs a savior with deep pockets, and in American healthcare, saviors with deep pockets tend to arrive wearing very particular cufflinks. Enter Ralph de la Tour. And understand, this man was not a stereotype of a Wall Street raider. Son of Cuban immigrants. Trained at Harvard Medical School and MIT. A cardiac surgeon by many accounts brilliant in the operating room, who ran cardiovascular surgery at one of Boston's elite institutions before crossing over to management. Charismatic, forceful, fluent in both medicine and money. When he stood in front of anxious hospital workers and promised a new model, community hospitals saved by private capital, run by an actual doctor, people believed him. Many wanted desperately to believe him. The capital behind him was a New York firm called Cerberus Capital Management, named with what would prove to be uncomfortable accuracy after the three-headed dog of Greek myth that guards the gates of the underworld. Cerberus specialized in distressed assets, failing car makers, troubled banks, and now hospitals. It put up roughly a quarter of the purchase price and pledged hundreds of millions in investment. The archdiocese blessed the deal. Regulators approved it with conditions. The chain was renamed Steward Health Care, a name chosen to evoke stewardship, careful guardianship of something precious. And here's what makes this story genuinely tragic rather than simply infuriating. For a moment, it seemed to work. Money flowed in. Facilities were renovated. Electronic records were installed. Steward began expanding, and the new model, physician-led, privately funded, community-focused, was celebrated in the business press. De la Torre spoke of building something unprecedented, a national network proving that community hospitals could be saved. Watch the dates carefully from here, though, because everything you just heard, the renovations, the expansion, the applause, happened while the clock was already running. Cerberus was a private equity firm, and private equity firms do not hold assets out of sentiment. Somewhere in a spreadsheet in New York, an exit was always scheduled. The only question was who would be paid on the way out, and who would be left holding the building, or rather, the rent on it. 2016 is the year the story pivots, and almost nobody noticed at the time. That year, Steward sold the land and buildings under its Massachusetts hospitals to a real estate trust from Birmingham, Alabama, called Medical Properties Trust, for $1.25 billion. Move one of the playbook, the sale leaseback, executed at scale. Hospitals that had owned their own ground for a century became tenants overnight, locked into long leases with rents that ratcheted upward every year. And a large portion of that real estate windfall did not go into patient care. It went out the door to Cerberus and its investors as a dividend. Think about what that transaction actually is. The one asset a struggling hospital can never replace, the roof over its operating rooms, converted into cash, and the cash converted into investor returns. The hospitals kept the scalpels and the payroll and the pension obligations. They surrendered the land. From that day forward, every Steward facility started every fiscal year hundreds of millions of dollars behind, owing rent on property it used to own. Flush with real estate money, Steward went on a national shopping spree. Dozens of hospitals across Utah, Texas, Ohio, Pennsylvania, Florida, Arkansas, Louisiana. Many bought with, you guessed it, more sale-leaseback financing from the same landlord. On paper, Steward was now one of the largest private hospital operators in America. In reality, it was becoming a rent-servicing operation with hospitals attached. Then, in 2020, with the expansion complete and the leases signed, Cerberus executed its exit, selling its stake to a group led by de la Torre and his fellow physicians. Total profit for the firm over its decade of ownership, roughly $800 million. Cerberus would later insist the hospitals were healthy when it left. Remember that claim. A bipartisan Senate committee would eventually go through the internal documents. And the extraction didn't stop when the private equity firm left, because by now the private equity logic was in the building's bloodstream. In early 2021, with the pandemic still filling its I see us and the company bleeding cash, Steward's new physician owners paid themselves a dividend of $111 million. The largest shareholder by far was Ralph de la Torre. That same stretch of years, he acquired a $40 million 190-foot yacht called Amaral, then a $15 million sport fishing boat. The company, meanwhile, operated 2 private jets worth a combined $95 million. Hold those 2 images side by side. A yacht the length of a city block, and a hospital supply closet where soon nurses would be counting out gauze. Because while the money flowed up, something else was happening down in the wards. Something the spreadsheets in Dallas, where Steward had relocated its headquarters, never quite captured. The people who worked inside those buildings saw it first. Ask an ICU nurse how a hospital dies, and they won't talk about balance sheets. They'll tell you it dies in increments. First, the little things. A specific catheter that's suddenly on back order. A broken elevator that stays broken. The printer paper that runs out, then the slings for lifting patients. Each item trivial. Each with a workaround. Until one day, the workaround is transferring a hemorrhaging mother across town because the device that would save her sits in a repossession warehouse. By 2022 and 2023, Steward hospitals had become case studies in incremental death. The company owed money to practically everyone. Medical device makers, surgical supply companies, the temp agencies that provided nurses, elevator repair firms, even the vendors who supplied food. Suppliers, unpaid for months, began demanding cash up front, or simply cutting Steward off. Court dockets across 8 states filled with hundreds of lawsuits and liens. At one Steward hospital in Florida, the problems became almost gothic. The facility made local news for an infestation of bats. Inside the wards, clinical staff were improvising a kind of battlefield medicine in peacetime America. Nurses at St. Elizabeth's would later testify about supply shortages in blunt, furious detail. Staff described mixing chemotherapy under expired certifications, hunting other floors for basic equipment, watching seasoned colleagues quit and not be replaced. In Massachusetts, state officials grew so alarmed they began stationing monitors inside Steward facilities, tracking week to week whether the hospitals could safely stay open. And this is where the story stops being about money, because the shortages had a body count. Sungita Rashid, the new mother from our opening, died in October 2023 after that embolization coil was repossessed over unpaid bills. Hers was not an isolated case. Federal lawmakers and investigative reporters would later link Steward's cost-cutting and supply failures to a series of patient deaths across its network. Each one a person who walked into a hospital that looked, from the parking lot, exactly like a functioning American medical center. That's the cruelest feature of this kind of collapse. The facade holds until the very end. The signs stay lit. The website still books appointments. From the outside, nobody can see that the institution has been financially hollowed, that the rent is devouring the payroll, that the owners have already been paid. By early 2024, Steward owed its landlord alone a sum it could never repay, and the fiction was running out of road. What happened next made history get like, for all the wrong reasons. May 6, 2024. In a federal courthouse in Houston, Steward Health Care has more than 30 hospitals, 8 states, tens of thousands of employees, hundreds of thousands of patients, filed for Chapter 11 bankruptcy, staggering under roughly $9 billion in liabilities. It was the largest hospital bankruptcy in the United States in decades. The company that had been founded to prove private capital could save community hospitals had instead produced the sector's most spectacular failure. A bankruptcy filing sounds abstract. Here's what it looked like on the ground. A fire sale of hospitals conducted against the clock, with Steward's lawyers warning the court there wasn't enough cash to keep the lights on while buyers were found. States scrambling to identify operators willing to take over facilities, some of which sat on land still owned by the landlord, Medical Properties Trust, which now faced billions in write-downs of its own. Doctors learning from news reports whether their hospitals would exist next month. For 2 communities in Massachusetts, the answer was no. On August 31st, 2024, Kearney Hospital in Dorchester, a working-class, heavily immigrant neighborhood of Boston, And Neshoba Valley Medical Center, the only hospital for a cluster of towns northwest of the city, closed their doors for good. No buyer, no bailout, no more emergency room. In Dorchester, residents now faced longer ambulance rides across a congested city. In the Neshoba Valley, the nearest ER moved half an hour or more away. Emergency physicians will tell you what those minutes mean for a stroke, a cardiac arrest, an overdose. The closures didn't distribute inconvenience. They distributed risk onto the poorest patients, the oldest patients, the ones without cars. Here's the detail that should stop you cold. The demand for healthcare in those communities didn't shrink. The heart attacks kept coming, redistributed to surrounding ERs that were already full. A hospital closure doesn't delete need. It just removes capacity and lets the need pile up in longer wait times and hallway beds across an entire region. Massachusetts officials forced to orchestrate emergency transitions for the surviving Steward hospitals described it as disaster response, the kind of operation states run after hurricanes. And as the wreckage was being sorted, one question kept surfacing in union halls and state houses, and eventually in Washington. Where did the money go? The hospitals were broke. But the money hadn't vanished. It had gone somewhere. It had gone to specific people through specific transactions, most of them perfectly legal. For once, Congress decided to name them, both parties together. September 12, 2024, a hearing room of the Senate Health, Education, Labor, and Pensions Committee. At the witness table, a name card reading Dr. Ralph Della Torre, a microphone, a glass of water, and an empty chair. The CEO of Steward Health Care had been served a congressional subpoena, a legal command, not an invitation, and simply declined to appear, his lawyers arguing the hearing would prejudice ongoing proceedings. Senators from both parties took turns addressing the chair as if he were sitting in it. It made for surreal television. The man who wouldn't come to Washington being described in Washington as the yacht sat in the Mediterranean. The Senate's response was without modern precedent. On September 25, 2024, the full chamber voted unanimously, every Democrat, every Republican, to hold De La Torre in criminal contempt of Congress, referring him to the Justice Department. It was the first time in over 50 years the Senate had taken that step against anyone. Days later, De La Torre resigned from Steward, effective October 1st, and countersued the committee, arguing the subpoena violated his constitutional rights. He has denied wrongdoing throughout. But the fight had already moved beyond one man. Because in parallel, the Senate Budget Committee had spent a year running a different kind of investigation, not theater, paperwork. Chairman Sheldon Whitehouse, a Rhode Island Democrat, and Ranking Member Chuck Grassley, an Iowa Republican, two men who agree on almost nothing, jointly subpoenaed and reviewed more than 1 million pages of internal documents. From Steward, from Medical Properties Trust, from Apollo Global Management, from Leonard Green and Partners and its hospital company, Prospect Medical Holdings. In January 2025, they published the findings under a title that requires no interpretation. Profits over Patients, the Harmful Effects of Private Equity on the U.S. Healthcare System. The report's power is its specificity. Internal board materials showing meeting after meeting devoted to cost-cutting, patient volume, and labor expense management, with, in the committee's words, little to no discussion of quality of care or patient outcomes. Documents tracing exactly how much cash left hospital systems as dividends and fees, while those same systems deferred maintenance and stiffed suppliers. Evidence that financial distress wasn't an accident that befell these hospitals, but a foreseeable consequence of decisions made in boardrooms. Decisions that reliably enriched the people making them. A senator from the left and a senator from the right, reading 1 million pages, arriving at the same sentence. That alone should tell you this stopped being a partisan story. But the report did something even more important for our purposes. It proved Steward wasn't unique. Sitting right beside it in those pages was a second hospital chain on the opposite coast that had run the identical playbook with an eerier discipline. If Steward was the loud collapse, this one was the quiet blueprint. Different coast, different firm, same anatomy. Prospect Medical Holdings ran safety net hospitals, the ones that treat you regardless of insurance, across California, Connecticut, Rhode Island, and Pennsylvania. From 2010 to 2021, its majority owner was Leonard Green and Partners, a Los Angeles private equity firm best known for retail brands. What Leonard Green did with Prospect is, thanks to the Senate investigation, one of the most precisely documented extractions in American healthcare. The headline number, $645 million. That's what Prospect paid out to its ownership group in dividends and preferred stock redemptions during the Leonard Green years. $424 million of it flowing to Leonard Green and its investors, plus another $13 million in fees. The bulk of it was financed exactly the way the playbook prescribes. Prospect borrowed against its own hospitals, including through sale-leasebacks with, once again, Medical Properties Trust, and handed the proceeds to shareholders. The Senate committee's conclusion was unambiguous. The payouts left the hospital system in severe financial distress. ProPublica later added a detail that reads like satire but isn't. Prospect had never even set aside money for malpractice insurance, leaving injured patients suing an empty shell. You can predict the third act by now because you've seen it once already. The unpaid vendors. The decaying facilities. In 2022, Prospect closed Delaware County Memorial Hospital and shuttered services at Springfield Hospital outside Philadelphia. In January 2025, the same month the Senate report landed, Prospect Medical Holdings filed for Chapter 11 with billions in obligations. And that April, the dominoes reached their heaviest piece. Crozer Chester Medical Center, the flagship hospital and only trauma center of Delaware County, Pennsylvania, 500,000 people, closed for good, along with its sister facility, Taylor Hospital. More than 3,000 healthcare workers lost their jobs. Leonard Green, for its part, has rejected blame, arguing the hospitals faced industry-wide headwinds. The county it left behind now measures trauma care in extra miles. I pause on the pattern because the pattern is the point. Two companies, different founders, different states, different decades of American medicine behind them. Identical sequence, acquisition, sale, leaseback, dividends out, rent in, decay, bankruptcy, closure. When one hospital chain collapses, you can blame a CEO. When two collapse in formation, followed by nursing home chains and ER staffing giants running the same choreography, you are not looking at bad management. You're looking at a system producing its designed output, which raises the uncomfortable question this whole story turns on. Anecdotes, even devastating ones, can mislead. Maybe these were the outliers, two rotten operators in an otherwise functional industry. To know whether private equity ownership itself degrades care, you'd need something colder than stories. You'd need data. Millions of patient records, private equity hospitals against matched controls, before and after acquisition. In December 2023, in the most prestigious medical journal in America, exactly that study arrived. Its findings are the closest thing this debate has to a verdict. The study was published in JAMA, the Journal of the American Medical Association, the day after Christmas 2023, by researchers from Harvard and the University of Chicago. Its design matters, so bear with 30 seconds of methodology. The team took 51 hospitals acquired by private equity firms and compared them against 259 carefully matched control hospitals. Similar size, similar patients, similar regions. Then they analyzed more than 4.5 million Medicare hospitalizations, before and after acquisition, asking one question: what happens to patients when the ownership changes? The answer: hospital-acquired adverse events, the injuries a hospital itself inflicts on you, rose 25% after private equity took over. Patient falls up 27%. Central line bloodstream infections, the kind caused when overstretched staff cut corners on sterile procedure, up 38%, even though these hospitals were placing 16% fewer central lines. And surgical site infections doubled, while surgical volume went down. Fewer operations, twice the infections. There is no charitable reading of that sentence. These are what clinicians call never events, the complications that vigilant staffing exists to prevent. They are, in effect, a gauge of how many nurses are on the floor. And that's precisely what makes the finding damning. The researchers noted the results are consistent with what you'd expect when acquirers cut staff to service debt. One more detail from the study, subtle but devastating. After acquisition, the patients at these hospitals were actually slightly younger and lower risk, likely because sicker, complex cases were steered elsewhere. Easier patients, worse outcomes. Whatever these hospitals were optimizing after the buyout, it wasn't safety. And the JAMA study doesn't stand alone. It sits on a stack. A landmark analysis of nursing homes found that private equity ownership raised short-term mortality among Medicare residents by about 10%, which, extrapolated across the study period, works out to roughly 20,000 additional deaths. Researchers found the same fingerprints: fewer nursing hours per patient, more residents sedated with antipsychotics. Meanwhile, in the emergency room, the private equity-owned staffing giants Envision and Team Health became the engines of America's surprise billing epidemic. Those four-figure out-of-network bills for ER visits, you couldn't have shopped around for while unconscious. Public fury over that practice got a federal law passed, banning it in 2022. Within 18 months, Envision, bought by KKR for nearly $10 billion, was bankrupt. Its business model, it turned out, had been the loophole: falls, infections, sedation, mortality. Billing designed for the moment you're least able to refuse. Different corners of medicine, one consistent signature. To be fair, the literature isn't uniform. Some studies of private equity deals in other healthcare settings find neutral effects, and the industry has answers to all of this. In the interest of honesty, those answers deserve a real hearing, not a straw man. So let's give the defense its day. Here is the strongest version of the argument, the one private equity executives make in congressional testimony and op-eds. And parts of it are more serious than you might expect. It goes like this: nobody else was coming. The hospitals we buy are already failing. Caritas Christi was drowning in pension debt when Cerberus arrived. No charity, no government, no health system was writing a check to save it. We provide capital where there is none. We modernize operations bloated by decades of complacency. And yes, we expect returns. Because returns are what attract the next dollar of capital to the next failing hospital. Without us, they close anyway, just sooner. Give the argument its due. It is true that many hospitals private equity acquired were already distressed. Safety net facilities in a brutal reimbursement environment that bankrupts nonprofits too. It is true that American healthcare is administratively bloated, and that some private equity investments, in outpatient clinics, in specialty care, show neutral or even positive results in parts of the research literature. And it is true that the deepest sickness, a system that pays for procedures rather than outcomes, was not invented by any buyout firm. Private equity didn't break American healthcare's incentives. It found them broken and moved in. But now run the argument against the documents. Because that's what the Senate investigators did, across 1 million pages. And this is where the defense collapses. If your mission is rescuing distressed hospitals, you invest in them. What the records show instead, hundreds of millions borrowed against those hospitals and paid out as dividends within a few years of acquisition. Rescuers do not execute sale-leasebacks that convert a hospital's last unencumbered asset into investor cash and perpetual rent. The "they would have failed anyway" defense has a math problem. A hospital that might have failed is strictly worse off after $645 million leaves through the front door. And when Cerberus says Steward was healthy at its exit in 2020, barely 3 years before nurses were rationing supplies, it's asking you to believe a decade of extraction and the collapse that immediately followed were coincidence. The most honest framing isn't that these are evil people. It's colder than that. A private equity firm has a fiduciary duty to its investors, a legal obligation to maximize their returns. It has no comparable duty to your grandmother in bed 6. When those two interests align, fine. When they conflict, and in a hospital running on 3% margins with a 5-year exit clock, they conflict constantly. The structure itself dictates who wins. You don't need a villain when the org chart is the villain. Which leaves one question standing, and it's arguably the biggest one in this whole story. None of what you've heard tonight was hidden. The transactions were filed, the lawsuits were public. Researchers were publishing warnings for years, so why did nothing and no one stop it? Not regulators, not courts, not Congress. Until the ambulances were already being diverted. The answer says less about private equity than it does about the referees. Start with a bizarre fact. For most of this saga, the federal government did not systematically know which hospitals private equity owned. Ownership hid behind stacked LLCs and holding companies. Medicare's databases weren't built to pierce them. Most acquisitions were individually small enough to slip beneath the dollar thresholds that trigger federal antitrust review. A roll-up of 30 small practices never faces the scrutiny one big merger would. The watchdogs weren't asleep. They were structurally blind. Then there's the older, stranger safeguard that failed, the corporate practice of medicine doctrine. Most states have century-old laws declaring that corporations cannot practice medicine. Only licensed physicians can. Private equity's lawyers dissolved that barrier with a paper structure. The physician owns the practice on paper, while a management services organization, owned by the fund, controls the staffing, the billing, the budgets, and the pressure. The doctor keeps the liability. The fund keeps the cash flow. A law meant to keep profit motives out of the exam room was reduced to a formatting requirement. 2 books mapped this machinery from opposite ends, and both are worth your time. Pulitzer Prize-winning journalist Gretchen Morgensen's These Are the Plunderers traces the industry's 40-year arc and lands on healthcare as its bleakest chapter. But the sharper indictment may be Brendan Ballou's Plunder, sharper because of who wrote it, a federal prosecutor who served as the Justice Department's special counsel for private equity. Ballou's core finding is the one this whole video has been circling. The firms are legally engineered to be unaccountable. The fund directs the strategy, the portfolio company absorbs the lawsuits and the bankruptcy. When a patient dies in a hollowed-out hospital, the entity responsible for the hollowing is, in the eyes of the law, usually just a shareholder standing at a polite distance. Add the quieter solvent, proximity to power. The industry spends heavily on lobbying in both parties. Regulators rotate into the firms they once oversaw. State health officials approving hospital deals face sophisticated legal teams and impossible choices. Block the buyout and the hospital may close today. Approve it and the hospital may close in 8 years on someone else's watch. For a politician, that is not a hard choice at all. And the connections run to the very top. Cerberus co-founder Steven Feinberg, whose firm's decade inside Steward you've just watched, went on to be confirmed in 2025 as the Deputy Secretary of Defense, the number 2 official at the Pentagon. So no, the guardrails didn't fail exactly. There were functionally no guardrails. That's what makes what happened after Steward's collapse worth paying attention to. Because for the first time in this story, the people writing the rules started rewriting them, and they started in the state that had watched Steward die up close. On January 8th, 2025, one day after the Senate report dropped, Massachusetts Governor Maura Healey signed the most aggressive law in the country on this subject. Written in Steward's ashes, it did something no state had done: banned hospitals from selling their main campuses into sale-leaseback deals. The transaction at the heart of this entire story, the one that converted Steward's land into Cerberus's dividend, is now, for core hospital real estate in Massachusetts, simply illegal. The law also dragged private equity firms and their real estate trust partners into the light. New oversight powers, financial disclosure requirements reaching up to parent owners, real penalties. 5 months later, Oregon went further down a different path. Senate Bill 951, signed in June 2025, attacked the paper structure itself, the management services organization shell game from the last block. Under the toughest corporate practice of medicine law in America, investor-controlled MSOs can no longer effectively own the doctors. Pennsylvania's governor, staring at Crozer's empty trauma center, proposed his own crackdown. Similar bills have been moving through state houses from Connecticut to New Mexico through 2025 and into this year. After 15 years of nothing, the states are legislating like a jury that's seen the evidence. Washington is the asterisk. Federal bills exist. Senator Ed Markey's Health Over Wealth Act, Elizabeth Warren's Stop Wall Street Looting Act, which would make private equity firms legally liable for their portfolio companies' conduct. And as of this recording, they remain exactly that: bills. The Federal Trade Commission did fire one warning shot. suing a private equity-backed anesthesia roll-up in Texas for allegedly buying up practices to jack up prices. But a 50-state industry with this much lobbying muscle isn't losing sleep over one lawsuit and two stalled bills. The referees are stirring. They are not yet on the field. And the Capitol? The Capitol has already moved. Watch where private equity healthcare money is flowing now. Hospice care, behavioral health, autism services for children, home care for the elderly, cardiology and oncology practices, the roll-up playbook migrating from emergency rooms to cancer clinics. The pattern matching writes itself. Sectors with vulnerable patients, reliable government payers, and thin regulatory supervision. The same three features that made hospitals irresistible in 2010. Which is why the Honest Status Report in mid-2026 is this. The worst single actor went bankrupt. The playbook got documented by the United States Senate. 2 states outlawed its signature moves, and the machine itself is intact, refinanced, and shopping. Whether Steward becomes a turning point or just a cautionary tale the industry absorbed and outlasted, that isn't settled. It will be settled quietly in state houses and agency rules and bankruptcy courts over the next few years. Which brings us back one last time to where this started. A supply closet in Boston and a bill that always comes due, just never to the people who ran it up. And Ralph De La Torre has never been convicted of anything, and he maintains his innocence. As of this recording, he splits his time between Texas and Florida. The yacht is still his. A federal grand jury in Boston has been examining Steward's executive compensation and its dealings overseas, and in Malta, criminal proceedings over Steward's hospital contracts, their grind slowly forward. Cerberus, for its part, walked away years before the collapse, $800 million richer, insisting to this day it left the patient in good health. The system's final verdict on the men who ran Steward is genuinely still being written. Its verdict on everyone else already arrived. The nurses got layoffs, Dorchester got a shuttered ER, and a little girl in Boston is growing up with her mother's photographs. Strip away the finance, and this story is about a collision between two duties. A fiduciary duty, the legal obligation to maximize returns for investors, and the duty a hospital owes the person on the gurney. For 15 years, American law allowed both duties to occupy the same building, and every time they collided, the fiduciary one won. Not because anyone voted for that outcome, but because one duty had lawyers, structure, and enforcement, and the other had a mission statement. A society gets to decide which institutions are allowed to be pure financial instruments. It just has to decide before the repo man reaches the supply closet. There's a practical takeaway here too, and it fits in one sentence. Find out who owns your hospital. Not its name, its owner. If the answer involves a private equity fund and a real estate trust, you now know exactly which questions to ask. Who holds the land? What's the rent? What happened to staffing after the deal closed? The entire model described tonight depended at every stage on nobody in the room asking those questions until it was too late. This video took a long time to research, and stories like this one, where the answer is buried in bankruptcy filings and Senate exhibits rather than press releases, are exactly what this channel exists to dig out. If it changed how you'll look at the next hospital you drive past, the two most useful things you can do cost nothing. Share it with someone who'd want to know, and subscribe so the next investigation finds you. And leave an honest comment, including where you think we got it wrong or what we missed. Tell us what deserves this treatment next. The money behind your insurance premiums, who actually owns America's nursing homes, or something we haven't thought of. The best episodes of this channel started as comments. Steward, in the end, kept its promise in the darkest possible way. The name meant guardianship, and the company did guard something, faithfully through every closure and every shortage, its investors' returns. The hospitals were never the client, they were the collateral. That's the quiet rule this entire story runs on, and it's worth carrying with you beyond healthcare because it applies to newspapers and retail chains and nursing homes and every other institution the machine touches next. When someone buys a thing people can't live without, using that thing's own future as the loan, read the fine print on who's guarding whom. In the boardroom, that question always has an answer. It's just rarely announced. Thanks for watching. See you in the next one.